Okay, so this is a SERB-sponsored symposium. Here are my conflicts of interest. So I'm on an advisory board for some companies, and I'm also part of a working group on guidance for thyroid emergencies. I clearly write too many guidelines. Right, so as an overview of what we're going to do, I have a case vignette, so I'll need a little bit of audience participation. We don't have any electronic voting, but show of hands will do. I'll talk about definition, epidemiology and presentation of myxedema coma, diagnosis and management, prognosis. I will touch on our draft guidance on managing thyroid emergencies. And I will also end, because there's only so much one can say about myxedema coma, really, I'll end on some alternative uses of levothyroxine. So straight into our case vignette then. This is a 63-year-old female patient who presents with acute confusion and drowsiness. She has a recent diagnosis of cellulitis and was started on flucloxacillin. Past medical history is of bipolar disorder, hypothyroidism and hypertension. And you can see that she's on a number of antipsychotic agents, lisinopril and levothyroxine. On examination, she is quite obtunded. She has a GCS of 11 out of 15. She's bradycardic with a pulse of 38, hypotensive, has a respiratory rate of 11 per minute, a saturation of 85% on air, and she is hypothermic. I think you know where this is going. She has a temperature of 33.1 degrees Celsius. On examination, she has clear cellulitis on her left leg, but there is not much else really to find on examination. She has no focal neurological signs, although she has slow relaxation of the deep reflexes. And her laboratory results confirm the clinical suspicion that she's very hypothyroid. She has a serum TSH that's greater than 90. So I've given these in my units, but the reference ranges are given there as well. 3T3 and 3T4 are low, and she has a cortisol that's 349.7. So my question to you is, in addition to supportive measures of this patient who's quite obtunded and administering IV hydrocortisone, which other treatment would you administer? Would you give intravenous levothyroxine, 400 micrograms? Would you give T3 intravenously, 60 micrograms? Would you give a combination of the two, 400 plus 60? Would you give T4 via an NG tube at a dose of 1.6 microgram per kilogram, or T3 via an NG tube? Anyone for 1? Anyone for 2? Anyone for 3? Anyone for 4? Can you see a hand there? And anyone for 5? Okay, I'll come back at the end. Hopefully we'll then all agree on what we should do. So myxedema coma was, of course, first described by George Murray, and this is when the first time thyroid extract was given. So this was a lady who was from being stuporous and obtunded with an inability to undertake housework and profound bradycardia following the administration of thyroid extract, made an excellent progress and was subsequently able to complete her housework again. Thank God for that. So, myxedema coma is decompensated hypothyroidism, and this is an endocrine emergency. It commonly presents with altered mental status, hypothermia, and depressed vital signs. Most patients are actually not comatose, despite its name. There is often an inciting event, such as an infection, and delays to diagnosis and management are common because people don't think about this. And as a consequence of this, it is still associated with very significant morbidity and mortality. So it's rare, luckily, and has an incidence of 0.22 to 1.08 cases per million per year. It typically affects women, as hypothyroidism typically affects women, and they're usually 60 years or older. And most patients do actually have a history of hypothyroidism. It's very rare that I've seen this in someone who presents with a new diagnosis of hypothyroidism. And actually, just as a show of hands, how many of you have seen a myxedema coma? How many of you have managed one? So, significant number. I probably see about 5 a year. I work in a big center, so obviously I get a sort of slightly skewed view of this. It's more common in winter months, and this creates a diagnostic problem, as often the hypothermia is confused for another reason. and the mortality remains high, still 30 to 60%, and like I said, that's because often the diagnosis is not made or the management has been inappropriate. And so I quite like the pictures in these case reports that have been published here. You can see how patients from being quite obtunded and significantly unwell, here unusually a man with myxedema coma, what a marked recovery they can make with appropriate treatment. So usually there's a precipitating factor, very often that's an infection, and since this often affects elderly people, it tends to be a urinary tract infection, a pneumonia or influenza. It's definitely much more common in people who are taking tranquilizers or narcotics or take other central nervous system depressants, and that is why it can often be difficult to diagnose. There are a number of stresses that will tip people over the edge, other illnesses, elderly people admitted to hospital for surgery or who have significant trauma, and exposure to cold. So I think, and I'll be talking to you about thyroid storm later on, so we were all well aware of diagnostic scoring systems for thyroid storm, but there is actually also one for myxedema coma, and it's only when I started looking in sort of putting some guidelines together that we found this scoring system here. And of course, as we know, thyroid hormones affect virtually every organ in our body. We have thyroid receptors in most cells in our body, but so most of the symptoms and signs that we get will localize to the systems that are most affected by thyroid hormones. So what this scoring system does is it looks at thermoregulatory dysfunction, CNS effects, gastrointestinal effects, cardiovascular effects, and very importantly, what we need to bear in mind here is that often these patients have significant metabolic disturbance, and then whether a precipitating event is present or not also adds to the scores. If the score is greater than 60, then this is highly suggestive of a myxedema coma. If it's between 25 and 60, it's suggestive, and if it's less than 25, it's unlikely. I've circled in red here what our patient would fulfill, so you can see that she easily gets to 60. Now, of course, when I do an acute medical on-call, many of the patients on my acute admission unit will actually easily get to a score of about 60. So I do think you need a little bit more than a scoring system to make the diagnosis. So there's not that much published, and there's certainly not many series published on this, as it is a rare condition. But so this was a study looking at 23 patients with myxedema coma, 87% were women, and it looked at predictors of mortality. The mean age of these patients, as I've already said, was about 60 years. It was published in 2008. But so independent factors that predicted mortality were people who had discontinued treatment with levothyroxine, people who were taking sedatives, people who were very bradycardic, and people who were hypotensive. If you had those people who had sepsis or unresponsive hypothermia, or those who required mechanical ventilation, again did worse. And at the bottom here, what's highlighted, I can't remember exactly what it was, but it's some sort of anesthetic scoring system that anesthetists use on intensive care. The higher the score, the worse people do. And again, this was an independent predictor. But what I want to emphasize here is that often these patients need mechanical ventilation support. So you do need to get a multidisciplinary team approach and involve an anesthetist early in the management. What do ATA, so the ATA guidelines on hypothyroidism, again, these are being reviewed, all ATA guidelines are being reviewed. Someone was just asking me, when will they be published? I know that the cancer ones will come out this year. I doubt that any of the others will come out this year. The hypothyroidism guidelines are not ready by any means, so they will be a while off. Anyway, in 2014, ATA guidelines said that you should give intravenous glucocorticoid treatment preceding levothyroxine. So you give hydrocortisone first before you give any form of thyroid hormone. And coming back to our case, the initial treatment really should be with intravenous levothyroxine. You would give lower doses of levothyroxine in older patients, as we would do with oral levothyroxine. And generally, you would only convert to oral therapy once the patient improves clinically. So these patients have a very edematous gut. If you give via an NG tube T3 or T4, it's not going to get absorbed. When I was little, a long time ago, the only treatment we had was intravenous T3. So all these patients I saw were treated with intravenous T3. We now have intravenous T4, and if there's one message that I can give you is that the treatment for this should be with intravenous levothyroxine. So you should avoid high doses of liothyronine. This is associated with increased mortality. This is very clearly documented. You can consider adding a little bit of T3, since the conversion of T4 to T3 will be impaired in these very ill people, and the ATA put this as a weak recommendation. I will come back to this when we come to our draft ETA guidelines. So this is an overview of what we are proposing. So if you have a clinical suspicion of myxedema coma, you take your blood test for baseline T3, T4, as well as a baseline cortisol. So remember, our patient had a cortisol that was about 350. I would probably expect a slightly higher cortisol in someone who is that ill. So that's why it's important that we give intravenous hydrocortisone. And then what we do is, with regards to a loading dose, this depends on whether the patient has underlying heart disease or not. In those with no history of ischemic heart disease, a loading dose of 400 micrograms of T4. If there is ischemic heart disease but normal left ventricular function, then you give 200 to 400 micrograms loading dose. And those who are very frail or elderly, and remember, a lot of these patients will be or have a low ventricular ejection fraction, you would give a lower dose of 100 to 150 micrograms. If ever you convert someone from oral to intravenous levothyroxine, the recommendation is that you reduce the oral dose by 25% to get an equivalent intravenous dose. So following a loading dose, you then generally give a standard dose, 1.6 microgram per kilogram. And generally what I would do is continue intravenous treatment for 2 to 3 days until you have a clear evidence that this patient will actually be absorbing what levothyroxine you give. You can assess the steroids levels. Like I said, it's best to take a baseline cortisol, and then they really require daily thyroid function testing. So your free T4 will be your best guide here. Your TSH is likely to be very high. Often, you know, in my lab, it'll say greater than 100 or greater than 90. So I asked the lab to actually dilute the TSH sample, because it's nice to see that actually the TSH is coming down with effective treatment. But your free T4 will be a good guide here. So this is what I discussed about depending on whether the patient has ischemic heart disease or not, you use a lower starting dose, and you standardly use a general replacement dose, but give that intravenously. But a lot of this is also about supportive care. So avoid too many sedatives. This makes these patients very unwell. Involve an anesthetist and give respiratory support if needed. Obviously, you would treat the infection. They do require careful fluid management and may need passive warning. These patients are very prone to get hypoglycemia, so this requires careful monitoring. Usually, these patients need to be managed on an intensive care setting, and therefore glucose monitoring generally will be good, but be careful of this, and I'll come back to electrolyte imbalance, but again, this requires careful consideration. So my policy is, if within 24 hours the patient is either getting worse or not getting better, I will add in a little bit of T3, a low dose, not the doses that I proposed in my case, but a low dose, something like 2.5 to 10 micrograms. Usually what I do is 2.5 twice a day or something like that. And again, I would generally give that intravenously. So what are the targets of treatment? So you will aim for a normal free T4, so mid-normal range. And obviously you want your patient to improve. So this is assessed by an improvement in mental status, improvement in cardiovascular and respiratory status, but you need to be aggressive here. Okay, these often are very frail, very elderly people who are very sick, and if you don't manage them aggressively, they will die. Okay, I've had 2 patients die this year where I was called in too late for advice. They had been piddling about with small doses of levothyroxine. These patients will die. And then obviously further down the line, you will address issues regarding compliance because often it has been non-compliance. These are elderly patients. No one looks after them. They forget to take their levothyroxine. They have an infection, and that's how they end up in trouble. Sorry. Okay, so this is in our proposed guidelines, and this is what we call the table of the H. So all these things start with H. So hypocortisolemia requires intravenous hydrocortisone at stress level. So you don't wait for your cortisol level to return. You give them intravenous levothyroxine. You give them a shot of 100 or 200 milligrams of intravenous hydrocortisone. You then give intravenous levothyroxine, and if no response after 24 hours, add T3. Don't delay intubation, so involve your anaesthetist and mechanically ventilate them if needed. They may need active rewarming of their hypothermia. And then, like many patients on intensive care, but these patients will be very prone to hyponatremia. So again, this requires very careful fluid management. SIADH may occur and can complicate the picture. I have only once had to use hypertonic saline in these patients, but again, if they're very hyponatremic and start having fits as a consequence of that, I have used hypertonic saline. They need careful volume expansion, but remember their heart may be very compromised. So again, this is a multidisciplinary approach, as well as management of their hypoglycemia. So this was the correct answer to my case vignette. I hope I've convinced you. Intravenous levothyroxine, we have good preparations available to us now, and it is really important. And it actually, treating a myxedema coma is very satisfying. So about 2 months ago, we had a patient, a 13-year-old girl in the Children's Hospital. Pediatricians there with 30 years experience had never seen one. So they rang me, asked me what to do. Within 24 hours of giving intravenous levothyroxine, this girl made a remarkable recovery. It actually is, it's very satisfying medicine to treat them, but very important. So as we're talking, so I'll just conclude on myxedema coma, and then I have a few more slides on other uses of levothyroxine. So this is decompensated hypothyroidism. It is dangerous, has significant morbidity and mortality. The key is rapid diagnosis, and the key is aggressive treatment. So consider this in patients with an altered mental state, hypothermia, refractory hypoglycemia, or hypotension. 3T4 is diagnostic here, and it's important to take a full clinical picture into account. Of course, you know, thyroid function test gets disturbed in people who are acutely ill. I don't need to tell this audience this, but take a full clinical picture into account and think, is this myxedema coma? It's important to provide both adrenal and thyroid supplementation and consider early use of vasopressors if the patient isn't really recovering and if you can't get on top of their hypotension. So what do we do in patients who have an inability to take levothyroxine? And, you know, we had a bit of a discussion last night over dinner with some of my colleagues here, but so these are some alternatives. And of course, not all of these are available everywhere in the world. So it's very good and well and good for me to tell you this is what you should do. If you don't have it available, then there's not much you can do. But so in patients who are unable to take tablets, you can use liquid levothyroxine. There are gel capsules. They have the advantage that they're actually absorbed. You know, their transit is a little bit more slow, and so they're absorbed more gradually. You can give intramuscular injections, or some of my patients go on once weekly oral tablets of levothyroxine. And again, you know, this is in specific indications. But so as a further case vignette, and this is a patient still under my care, this is a 42-year-old female patient who had a duodenal cancer and had a duodenal resection for this. Within 24 hours, she infarcted her whole small bowel, and all small bowel was removed, and she then had a venting gastrostomy, and a little picture of a venting gastrostomy is shown there. So she has a TPN feeding tube, or the TPN feeding line, and is unable to absorb anything. And she was hypothyroid. So she'd been diagnosed with autoimmune hypothyroidism before her bowel cancer, and was on oral levothyroxine. She had been established on intravenous T3, and I was actually completely unaware of her, and this was injected on a daily basis by her husband through her central feeding line. But then the GP contacted me and said, they're stopping me from prescribing this. We work in an NHS system. T3 is too expensive. We can't prescribe it. What do I do? So this is actually the first time I started using intravenous levothyroxine. So we established her on intravenous T4. She has been on it for 8 years now. I actually rarely see her. She comes once a year just to say hi, really. So we supply her with the intravenous levothyroxine. Her husband gives it to her. She's a very tiny lady, so she only needs 100 micrograms twice a week via her central line. And generally, we make this up in 100 mils of normal saline and administer it over 30 minutes. It works a dream. So I have 2 patients who are on chronic intravenous levothyroxine, this lady and then another lady who has CREST syndrome. Again, there's absolutely no absorption in her gut. She has a TPN feeding line, and we give her twice weekly levothyroxine. It's important to give it twice a week. I tried once a week because, generally we don't like too much manipulation of a central line. But it doesn't, the steady state, it sort of drops too much in the middle, so twice weekly is appropriate. And then just to end on a final case, and again, a sort of, because essentially I think there are 3 groups in which you can use intravenous levothyroxine. There's the Myxedema Coma patients, and there it's temporary, but acute, and very important that you do it. There are then patients who need it chronically. Again, that's very rare, but there are a number of patients. And then we do use this on intensive care in a number of patients. So this was a 34-year-old male patient who had extensive medullary thyroid cancer that invaded the trachea and esophagus. He had multiple extensive surgeries to remove his cancer, and, quite heroic, really. I mean, this man had so many surgeries, but essentially they removed everything and then reconstructed it. So he had a reconstruction of his trachea and esophagus. So he spent months and months and months on intensive care. You can see him there. You can see his extensive scars. I mean, this man actually was transferred from another hospital where they said, this is inoperable, there's nothing we can do. And 2 years on, he is still alive and doing quite well. So he needed levothyroxine because everything had been removed, all his thyroid gland had been removed. He had had so many surgeries and so much of his organs had been removed. So he was unable to absorb levothyroxine, and he was managed with intravenous levothyroxine on ICU for many months. And like I said, a conversion from an oral to intravenous dose is a reduction of 75%. So I do think there are indications for use of intravenous levothyroxine. They are rare, but so it's the Myxedema Coma patients, chronically in patients who are unable to absorb, and then patients who are unable to swallow on ITU. It's being unable to swallow, but it's also being unable to absorb. Okay, because sometimes people have an NG tube, but if their gut or their their bowel is all edematous and they're not going to absorb, then administering this intravenously is important. Thank you very much.